the lady was saying, well, she was labeled rightly as a gerontologist. And she was saying how many years it takes to before you actually fully qualify for that tag, gerontologist. I know I have discerning listeners, so be mindful of these terms and titles I put out there, because we're still in our anniversary mode. We've had to postpone some of our gift giving, but it's because you're a discerning listener, you'll know some of these distinctions. So, gentlemen, you're welcome. Let me start with you, Dr. Kwesenu. Have we met? Not too sure.
Yeah,
you look familiar. You look very familiar.
You taught me many years ago.
From today, none of my. Well, that's great. But a program on healthy aging at the Ghana Health Service. Okay, last week I was hitting hard. I said, look, we know what should be, but on the ground we don't have it. Just tell us quickly, briefly, a bit about the National Program on Healthy Aging.
Okay, so I think in response to what we are seeing globally, the fact that right from 2021 to 2030,
right,
WHO has earmarked it as a decade of healthy aging.
Right.
So it requires that countries place themselves in readiness in making access to healthcare to all the elderly,
right,
wherever you are. And I think because Ghana is a part of WHO, we are taking big steps to achieve that, especially when our own national policy tells us that we want to make sure that everyone have quality care,
right,
irrespective of whether you have the ability to pay or not,
right,
no matter who you are. That includes the vulnerable adults. So I think it's been in response to the global shift. And you and I know how COVID also taught us a big lesson of the need to take care of old people in a good way.
Right.
And I think that's what it is now.
Okay. All right, folks, if you just listen to Dr. Kwesenu, and I'm going to put him on the spot a bit here, because he says that, look, we have a program, National Program for Healthy Aging, which also encompasses taking care of the aged as a vulnerable targeted group, right? And the reason I said I'll put him on the spot is that he says we're taking big steps. I'll be seeing how big and what we're actually doing, because it fits into the context of what we're discussing, right? We mentioned that as we develop, as we enhance our capacity and, should I say, harness technological and other advancements in medicine and healthcare generally, people are living longer. And that is great. Call it answered prayer. But alongside that means that there are also certain consequences, right, that we should be prepared for and should be able to address, right? So the health care needs of the elderly. Last week, we established a kind of threshold, 60 and above. I've seen some countries, they even talk about 55 and above, which kind of catches me, so I don't like that one. But yeah, 60 and above, I'm not there yet, but we all get there. And we're talking essentially about healthcare, the provision of healthcare services, right, that identify, diagnose, treat, manage, and I guess my guest will give you the distinction between treatment and management too, right? Some of these things. And Dr. Akwa also pointed out last week that one of the objectives is also to prevent the development of some of these conditions. So today we'll go into a bit more detail, but I'm happy there's a program. I've been aware of it, but I like it being articulated by those who sit there. All right, so coming back to what we did last week, we established a few things. We understood that there must be specialized service delivery for the elderly. The mode and manner and maybe even structural arrangements within which we deliver to these people. The fact that we would like and wish for them to have a one-stop shop where they are not hopping with difficulty from one specialist to the other and so on and so forth. Ernest and George, if there's anything you want to recap, just briefly, quickly from last week.
Yeah, basically that's it that we said. We made mention of the fact that as one grows, chances of developing numerous diseases come along, and the need for one to take more drugs also comes to play, and the need to manage all these things in a coordinated fashion, just as we are talking about. The elderly have other issues too, psychosocial issues like neglect and abuse, and it's imperative for society to know how to promote inclusiveness of the elderly in how we design our homes and other public institutions to make it aged friendly for them to be able to access and feel a part of us. Okay.
Great stuff. So, folks, feel free to chip in. WhatsApp is 055 11 11 997. Our phone line 0302 216 541. I do believe we are live and active on Facebook. Still a bit of a niggling challenge with YouTube, but you can get in touch with us and share what your experience is, whether you are in that age bracket or you're taking care of an elderly or aging relative or spouse or maybe a friend, right? Do you witness these things? Do you see them as manifest in our health service, right? And then, of course, you can share your questions. So coming back to some of these things, reading talks about things like arthritis, osteoporosis, bronchitis, the cardiovascular diseases, the diabetes, and all of these things. Then, of course, we have in there the cancers, and then the dementias and many others, right? I tried to get a ranking of common presentations, right, last week. We may not get it spot on, but we did talk about falls last week, right? And I realized, and I guess it's logical, these may be related to changes in motor ability, joints, and so on and so forth. And that brings in, let me hit this one firstly, arthritis. I read that it's also quite common in this target group. Doc, you're nodding. Would you want to take a bite at that? Most people hear arthritis even in lower ages, right? But what is it, and why is it a problem in this age group?
Okay. So I think that basically when we talk about arthritis, we are talking about the changes that occur within the various joints of the body.
Okay.
Most of the times, it becomes a big deal for older people, especially in the bigger joints, like your elbow, like your shoulder, like your knee, sometimes your ankle. It comes along with a lot of pain because you see the joint is made such that it's supposed to move. One bone is supposed to move
over and against another. Right.
And you have some mechanics that helps that smooth movement. But as one ages, a lot of changes occur. Those fluids that are within the joint space that allow this smooth gliding movement sort of reduce in production.
Right.
At the same time, too, as we all know, even when we buy new cars, you have
wear and
tear.
Right.
And that is one key thing that happens to many joints. In fact, arthritis is one of the things that really makes us understand that process of growth is also about wear and tear because it's easily understood by that. And most people would have pain in their knees, will have pain in their elbows. Some will say that I can't lift my hand above my head and all that. And all is because the joints in there have become stiffer than they are supposed to because of the reduction in these fluids that surrounds the joints, and also the if I'll say the smooth area of the bone, which we call the articular surfaces, which have become deteriorated with time. And that is why it's seen more in the older adults.
Right. So last week we talked about movement and various ranges and types of quick screening and assessments that we do, right? But Ernest, I'm sure this would also compromise mobility.
Yes.
And it would need to be, should I say, screened for, identified, diagnosed, and treated and managed for this category of people.
Yes, yes. So, good afternoon once again. Thank you for the opportunity. It's always an honor to be here. So, with regards to what you said, arthritis is a very debilitating condition, more so because it is a degenerative process that keeps going on. In fact, most of the treatment that is offered in the hospital setting would help slow down the rate of deterioration rather than, as it were, solve the problem altogether. So when an elderly person is confronted with this condition, like you mentioned early on, mobility becomes a problem because many a time as there's friction or there's movement, the pain becomes worse. And so they are not encouraged to move. But the thing is that as you grow older and your mobility decreases, the same way the muscles, we call it's a phenomenon called disuse due to atrophy. So when you don't exercise the muscle, anytime I use the word exercise, I need to explain because many a time people hear exercise and they equate it to hitting the gym. Being in the gym is good, but exercise is not restricted to the gym.
Being physically functional.
Exactly. So it's about the repetitive nature and being intentional. So if an elderly person or an old person is discouraged because of pain in the knee or in the shoulder and doesn't move, inadvertently what they are doing is that the muscles become weaker because they are not being used every now and then. And the risk of falls, because the skeleton or the bones act like a scaffold. And so when you are not moving the muscles well enough, then even though you may have a good setup of bones, the muscles that will support the motion is weak. And so the risk of falls is high. And so in this group, even though we would encourage for them to be a bit slow, we also encourage them to allow some level of movement.
There must be some range of activity
movement.
and physical function.
Otherwise staying stationary in itself becomes very counterproductive.
Great stuff. 24 minutes past the hour of 2 already. And this explains why we will get into the chronic care team, right? But this is why we need occupational therapists, we need physiotherapists as part of this whole geriatric medicine team, right? So that's why we're running through some of these things quickly so that you can also get in your questions. WhatsApp is 055 11 11 997. And we're live and active on Facebook and YouTube, Ultimate Health on Joy 99.7 FM. The rheumatoid arthritis is the one which is more autoimmune related. Yeah. Okay, but it's the same basic.
Yes, thing. But in the elderly, it's similar. But in the elderly, the commoner diagnosis when it comes to the antibody-related arthritis is what we call the polymyalgia rheumatica. in terms of the pathophysiology or the way the presentation is similar, but it is commoner to have that kind of rheumatoid arthritis in the elderly, referred to as the polymyalgia rheumatica. And like Dr. Pesenu mentioned earlier, it affects usually the girdle, the shoulder. So the presentation is similar. Rheumatoid arthritis typically affects the smaller joints, and it is commoner in younger people, especially females.
All right. So you see why he's in the seat and I'm across here doing all the muff. But if you just joined us, this is Ultimate Health on Joy 99.7 FM. We're talking about the healthcare needs of the elderly, right? We're looking at a range of age-related changes. There are still health conditions associated with younger people, but they are more acute or more serious and need a serious, deliberate focus from the health delivery system. That's why I've gathered the gentlemen in the studio and we are continuing this discussion. Shortly, I'll activate the phone lines. If you have any questions, WhatsApp is 055 11 11 997. So associated with this, we also hear osteoporosis, right? Changes in bone density. We know don't pay when we are eating, right? But what happens to our bones, Dr. Aqua, as we age? And in this particular target group, what do we mean when we say osteoporosis, and what are the kinds of problems that may typically present?
So typically as we grow, the bone mass reduces. The substance that makes up the bone itself declines. Principally, we are looking at calcium. Calcium deposits in the bone goes down, especially with women. It's in association with an imbalance of their hormones, the estrogen, and its depletion is partly responsible for the losing of the mineral matrix in the bone, and for that matter, what we call osteoporosis.
Right. So just a second. So as we are young, functional, and all that,
yes.
right? There are certain processes, certain hormones, certain chemicals, or let me call it body chemicals, that maintain.
Yes.
Right.
Yes, the integrity
of the bone that we depend on.
Exactly.
Right, and you're saying with age and sometimes with some disproportionate burden on women because of the hormonal things you're talking about.
Yes.
We lose the density, the strength of the bones.
Exactly.
Okay, and this will happen over time.
Over time.
So therefore, it falls into the category we're looking at.
Yes.
Okay. Right. So you're losing bone density.
Yeah.
All right. As I sit here, well, maybe so you could be as plump as Dr. George Aqua, but that has no bearing on your bone density.
Exactly.
Or your bone health.
Yeah.
Okay. So it's not about your size.
Yeah.
Or your girth. No.
No. Your age and then your gender.
Right.
Being a woman makes it more.
Okay. So would you say that typically in this target group or in this area of medicine, this is something we would look out for or screen for?
Yes, there are various screening modalities available for osteoporosis, for serum calcium levels. They are readily available in most of our clinics.
Right.
Yeah.
Okay.
And it's advised that women in their menopause take supplements to replenish these losses too.
Okay. Great stuff.
As a preventive measure.
So I'm hearing stuff that makes it, quite kind of validates the people I have in the studio. But you see, where you talk about a doctor sitting in front of you, and what was the painful one you mentioned?
Polymyalgia rheumatica.
Now, you may be sitting in front of a physician, but let me come to you, Dr. Pesanu. I mean, does the average physician have this spectrum, this perspective that, okay, just based on your age and your presentation in a hospital, I'm looking at this range of things alongside your presenting symptoms, and I'm very, very, very capable, right? And I possess the requisite training, skills, expertise to look into this as age-related changes that must be managed.
Okay. So I think that as you are being groomed as a physician, there are certain things that you would be taught to do. And one is looking at the life course approach. So the way you deal with children is different from the way you deal with younger adults.
Okay.
The same way with the older adults.
Okay.
I must say that just the medical school knowledge will not make you decipher all the problems.
You must go higher.
Yes.
Young way.
So in as much as the basic knowledge usually is possessed by most physicians, there are still some core things that you would need extra training to be able to.
Let me give you a hand by saying my basic root question is, so do you require to quickly move to a specialist or a family physician or whatever, rather than going to a general OPD with some of these age-related changes we're talking about?
So, because I'm a family physician, we are primary care people.
Okay.
And we are like the gatekeepers.
All right.
We tell you where you need to go.
Okay.
In actual fact, without us, it is difficult for you to know that your problem requires a cardiologist.
Okay.
And so most doctors would be trained to have that basic broad knowledge, like a family physician, even though you would acquire more skills when you do extra training. So anyone, before you can see any specialist, must necessarily be seen by a doctor.
You must go to the lower tiers,
yes,
and then you'll be referred appropriately.
Yes, please.
Okay.
So once that happens, as Dr. Aqua is saying, there are certain things that can be screened for even at the general practice level.
All right.
Some of them, in as much as they are something like osteoporosis, even though calcium is part of the things, you are supposed to also do things like bone scans, which are expensive, which are also usually not too available.
Okay.
As it stands now, you don't have many radiology units that are able to do these scans.
Okay.
So right from the onset, you realize that even making a diagnosis with evidence becomes an issue.
That is why a lot of these people we're talking about hop from place to place and place. They say, I was treated for this for 4 years, and then now finally they've arrived at this.
Yeah.
And they tend to think that, well, the physician I was seeing in the earlier phase didn't know, I don't want to use the word, right? But was not helping me. So that's why when you said, well, we've set up this program, National Healthy Aging Program, at the level of the GHS, Ghana Health Service, and therefore we are responding in big ways. But you are also pointing out that we lack the requisite tools, right, or advanced tools that help us shorten the journey and make life easier for these people, right, experiencing these age-related changes. Okay, so that's why I was asking, perhaps, well, if I go straight to the big shots like you people, then they'll go there straight and say, we require this, or we think it is this and that and that and that. But we still are able to identify them,
yes,
and respond to them.
Yes, please.
Okay, great stuff. This one says, please, I'd like to know if the type of fish matters. I learned that fish with dark skin and fish without scales are not preferred varieties for healthy eating. Also, the very dark fish in flesh in tuna, is it supposed to be eaten? What nutrients does it give? So please list the sources of plant protein again as alternatives. Let me just see those something, because it looks like this could have been for an earlier. Okay, right. It was for an earlier program. That's why I was surprised. That was the Meatless Monday program. But this one says, hello, Nortey. So if you are elderly and you stayed inactive for a long time, such that you've already developed weak muscles and muscular pain and stooped gait, can this be corrected or reversed? What exercises can we do to build strength in our muscles? Again, any exercise websites to recommend, since the program can't show us all. So the earlier ones was related, but she's talking about, well, some of this has taken place already. You may have compromised joints and so on and so forth. You mentioned atrophy, right? Yes. Wasting due to disuse. Yes. So she's saying, can it be corrected by some kind of exercise or physical regime, or is it too late? Does it have to be properly diagnosed and then addressed as a condition?
Okay, so to start with, in terms of reversal, not complete reversal, because once you've lost the muscle, it's taking a bit of time to have get to that point. Okay. So in trying to reverse it, you are not aiming at actually regaining all the muscle bulk. Okay. But what you are trying to do is to prevent further loss.
To slow it down.
But whilst you are at it, there is likely going to be an increase in the muscle bulk again. Okay. So we are trying to measure expectations, so the person doesn't say, "Oh, I lost this much muscle, I lost so much weight, I'm hoping to get back on the treadmill so that I gain all of that." No, that's not the motive. The motive is the benefit that comes with you keeping active. Okay. Even aside the musculoskeletal system is good enough for the heart and other system. So there are different types of exercise. There's the aerobic, there's the flexible exercise, there's the coordination. So you want to have a mixed bag.
All tuned individually to your situation and
yes, to the person's strength. And about the person stooping forward and those gaits, sometimes it comes even with the ergonomics, where the person, aside being active, maybe because of the kind of work they did, they'll develop it. And sometimes you can have a particular condition like Parkinson's disease, where the person stoops forward and has a shuffling gait. So I think it depends on the person, and like you mentioned early on, once a diagnosis is made in the setting of a multidisciplinary team, you can always coordinate with a physiotherapist who will make a tailor-measured exercise regime for him or her.
You just reminded me, I had to see let me say an older person. I think he was close to his 80s, right? But he'd gone to see his physician because he was not happy with he said people were commenting on his stomach and his gait, and this was a problem. And so he was seeing a physiotherapist and even a dietitian. And I was like, Dad, but this your stomach at your age, your body is not that bad. But maybe you're looking back, on how you used to be. But at your age, there's nothing too abnormal, though you can seek to look healthier or be fitter. But the kind of expectation he was holding was that, hey, and I said, oh, Dad, so do you want a six-pack? Right? In your 80s. Yeah. So sometimes there's some psychological components to it that you need to be able to accept certain changes whilst working to be fit and healthy.
Yes.
Right. This one says, greetings to you, Anchor. I guess that's me. and your indefatigable practitioners. You just want me to slip up with my tongue. That's why you write all those big words. But we receive it. My question is the kind of psychological. It's kind of psychological with regards to the aged and the changes. Okay, but I don't see the question. Okay, yes, we look at cognition, mental health or mental wellness and adjustment. Okay, so it also comes in. So probably that's what they're pointing to. We'll see if we can get to that. This one says, my mother tends to respond to issues somehow in a harsh manner and behaves out of the ordinary, which has made her caregivers to always have problems with her. Right, mood shifts and some other things come in. Some even become paranoid and suspicious. Right, and it's difficult to pair them with a caregiving team. I think that's what you're referring to. Caregivers always have problems with her! Exclamation mark. Right. What advice would you give with regards to her condition? This is Herman Fiakojo. Right. Well, you don't give us too much, but definitely there are some behavioral and emotional issues that need to be looked at. Sometimes you're not well physically, and you may have a secondary emotional condition developing alongside that, or it could be the other way around. But again, a multidisciplinary team is able to identify these things and then make sure that all of the components are being addressed. I don't know whether any of you want to comment on that.
I think is it Herman's question? Yeah, so there are so many subtle things that in themselves might be medical conditions that show forth. Definitely, for older people, issues with their thyroid is one of the things that we often battle with, and it can come with mood changes. And so it's always necessary for us to take a comprehensive approach towards their care. I must say, a lot of older adults also have mood problems, which can result because of their own trying to respond to the changes they are carrying. Like the story you gave about the man with the
tummy and
so we must understand that a lot of things change with aging.
We are dealing with change.
That's it.
Right.
Your muscle itself, it gets to a time where it's replaced with fat. It's part of the aging process, what we call sarcopenia. So irrespective of how active you are, at a particular age, you realize that you lose your muscles with which is not even a fault of yours. It's just the aging process. However, that even results in sometimes a slowness and not being able to take up what you used to and all that. But at that level, you are still healthy, because you can still function, you can still do the things you are supposed to do. So it's just a matter of accepting that stage.
So you need help with that insight and that acceptance.
That is very, very important.
And sometimes more likely professional help with that.
Yes.
Okay.
Yes.
Right. Okay. 40 minutes past the hour of 2 already. We're making some progress. Let me ask this question, because I was discussing with you before the program. You know, all of these things, we are now placing them under the umbrella of geriatric medicine. Okay, so we are aware of all manner of changes that are taking place in this person, in this patient, in this client. I mean, sometimes let me put it this way, let me play ignorant, but do we put premium on what the person's response to these changes are? So, for example, I need to wear adult diapers or adult pampers, in quotes. I need help with my personal hygiene, with passing feces, urine. Now they need to balance me on a bedpan. All right? Everybody's happy because they've been able to source and procure the bedpan, but I am not happy. Right? I am not happy that I have to take medicines for the painful long one that Ernest mentioned. I also have diabetes. I also have this. We talked about polypharma the other time. But how much premium do we place on the psychological behavioral changes that take place. So, for example, I may even be annoyed that you are spending money on a carer for me, right? And therefore, I need to do everything to prove to you that it wasn't needed. Yeah. On your level, on your side of the coin, George, how much do we put into the kind of care teams we build around this, whether in facility in the hospital or when we're giving home care?
So ideally, as people are growing, we need to take care of, first of all, their caregivers, their immediate caregivers being often their children,
right?
And then also the
children and relatives who don't have a choice.
Exactly. And then also those who live with them. So we've got to educate them to a good degree on the issues they are going to encounter. And we've got to prepare them psychologically. That's at a point in time they're going to come up with emotional and psychosocial issues, and we need to be there for them. So we
need to build the capacity of your caregiving or your support network
team. Exactly.
Right. Okay.
Exactly. Yes. So we need to know them of the make them know of the financial consequences they are going to bear. That they are going to buy bedpans, buy beds for them at home, buy
and not just for 1 week.
Yes. Yes, and actually things are going to even get worse, and escalate along the line. So they need to arm themselves well. So basically, it's about the information. There's a lot of ignorance on the part of the caregivers and the patients themselves. So we need to educate the patients. We need to educate their family, their children in totality. Give them a broad idea of where we are heading, so that they can buy in.
Do you need to be more empathic, more tolerant than the average, in quotes, physician, because you're working with this target group? You know, the pediatricians have their way with the kids, right? So I just want to share with my listeners, and let me just remind my listeners, phone line is active, 0302-221-6541. We prefer your questions. Me, I'm just a bookman. Right, so you can load yourself, but let's see. I mean, do you have to download a certain new disposition as a physician handling these kinds of things? Because you get into a house and there's a whole fight, sometimes among siblings, right? Sometimes the patient or the client themselves is also or has also taken a certain position, right? And you go in there and you're supposed to fix it all. Some doctors will say, well, this is my psychology, my social worker, right? I'm not an NGO, right? You find the money, buy the commode, buy this, that. Then we are in business. How do you handle this? And do you typically have to demonstrate a new skill set? Yeah?
Okay, so what I can say basically is that as you have rightly pointed, once they get to that stage, they require a lot of show of empathy. And we must appreciate that most care workers, healthcare workers, are, if I'll say, very busy with their work. Maybe sometimes they have to see a lot of people and all that. So they don't spend time to go into some of the psychosocial aspect of care, which for an elderly person is a very big deal. And for that matter, will require more time. Dealing with psychosocial issues require time. Unlike probably a medical diagnosis that might take
your BP,
15 or
this is your sugar level,
that's it. So a lot of time we sort of then throw it to maybe those that can be of help, maybe a social worker.
Does the program provide that kind of support for the physicians you put out there?
Okay, so I think for us to understand what big steps I am talking about, it will be clear so that we know how far the program is and what can be done. Okay, so the concept for the program is to have, if I'll say, a team-based approach towards the care of the older person.
Multidisciplinary team.
Yes, multidisciplinary team. At the district level, at the sub-district level, even at the tertiary level of care. So that's what we want to look at. That at every setting, as far as we are caring for an adult person, whether it's an OPD setting, it's in an inpatient care or whatever,
you should have access to this range of professionals.
Yes,
you should.
Yes.
Okay.
So that is the basis.
I'm waiting for where it gets to you shall. You must.
So when we are talking about the big steps, most of these things are stemmed on strong policies.
Okay.
And I think if we get the policies right, then the direction becomes easier.
Do we have a specific policy document on this aging or the care of the elderly?
That is in the process of being developed, actually.
Okay.
As it stands now, we've gotten to a stage where we need to validate the document. So it was put together by a group of healthcare practitioners, social work, people in the psychology, psychiatric, geriatricians, physiotherapists.
So all the disciplines have contributed to a document on what? Geriatric medicine or geriatric care?
Yes, on the care of the older adults in Ghana.
All right, okay.
Under the Ghana Health Service umbrella.
Okay.
And this is largely built around what we call the integrated care of the older persons by the WHO, which insists or which requires that you have this multidisciplinary approach towards the care.
Okay, so essentially what we're doing is we're fine-tuning it to our circumstance, and then we have to go through the law, the ayes have it and all that, and then we get a document.
Yes.
In the meantime, you guys are practicing.
Yes.
Right. So we still have these gaps, all right?
Yeah.
Okay, so you've identified the big movements, but some of the challenges with the big movements.
Yeah.
See, the reason I ask these questions is that years ago, I used to set questions on things we didn't have in exams, right? For example, tobacco control, when I do substance use disorders and all that. For years, we didn't have our tobacco control until finally 2011, we had the public health bill. And section 6 of that gives us our comprehensive tobacco control regulations, and still alcohol is flying around there. We haven't touched alcohol yet, and so on and so forth. So it's great when you get to do a program, you can actually tell your listeners this has been hammered out in a living policy document. So that's why I'm so happy having you here as an acting coordinator. So you are still coordinating, but these are the things we want our listeners to also understand. Let me quickly read this out. Hello, Nortey. Beautiful submissions by your medics. May I know if osteoporosis is treatable and what percentage of men does it affect? Okay, I suspect you may be male. How long can the bone implant remain in the body after conducting surgery at 50 years or 50, it can't be 50 years ago, at age 50, I guess. Greetings to all, especially Dr. Kwesenu Kuku in Mampong. His constituency, right? Because he's stationed at the Tetekwashi. Any response to this?
Okay, so osteoporosis can actually not be cured, but it can be managed.
All right, that is what we said was the loss of bone density. For various reasons. Yes.
And as Doc rightly said, it has a lot to do with hormones.
All right.
However, it's not just women that can have.
Okay.
We know because of estrogen cessation related to your menses, which would happen in women.
Right.
You would have more women having that problem. As compared to testosterone in males, which will also sometimes go down as you age and can also result in these problems that we are talking about. So it cannot be, if I'll say, cured entirely, but there are some medications that help in making sure that the calcium that is being lost is replaced or it's not getting out of the system as fast as it should. So I think that's one of the things. And he was talking about bone implant. So I don't know if it's because he's had
some orthopedic process or
something. So it depends on the material. If it's a hip implant, it's going to be there forever. If it is, if I'll say, a plate that can be removed after the bone heals, that can also be removed. But it depends on.
And typically, you'll be told if it's supposed to be long-term or permanent. Right. If it's something that's serving a purpose and will be removed or extracted, you'll be told as well. Great submissions. Thank you so much. Can I get any of the health professionals' contact? That's what people love. Ethically, they are not really permitted or encouraged to give out their personal numbers. It turns our program into a kind of advertising platform for practitioners. We try to steer away from that, though some give out their numbers. But they are all available at the facilities I've indicated. Dr. Kwesenu practices at the Mampong, the Tetekwashi Hospital.
Yes, please.
That's Mampong, isn't it?
Yes,
yep.
Please.
Okay. And then Ernest Enim Opari, Doctor, Reverend, and football coach. Disappointed Tottenham fan. He's at the Kolebu Polyclinic. Okay. And Dr. Aqua is with the Department of Community Health, right?
Yes.
So if they want to find you, that's where they'll find you. All are in Kolebu, okay? But any other doctor can help you and assist you with referrals, okay? Sometimes when you give out your number, you don't sleep. All right. This one says, Dede in Maryland. Dede, you're welcome. Didn't hear the waist being listed as one of the areas that can be affected. Oh, they mentioned all the joints, right? Talked about major and minor ones as well. You have waste management issues, not of the Zoom Lion type. Does it or does it not? Dede wants to know about CC and waste. Hemingitis, as the guys will say hemingitis,
like
waist
said,
pain and waist problems.
It's part of it. It's part of it.
Right.
So the shoulders, the knees, the elbows, and the waist. It's the pelvic region, the pelvic girdle. So it's all part of it.
All
Maybe
right.
she didn't hear us.
But we would like to know. Okay, I'll sidebar you, but Dede always likes us to be specific. So when she starts typing from Maryland, I know that we said it, but it probably wasn't specific. All right. So we talked about bone density, bone loss. We talked about that last week. We talked about, of course, the usuals, right? Strokes, cardiovascular diseases and conditions and so on. What I want to do as we quickly run out of time, I'm begging Beku for a few extra minutes as well. Having all these in tandem or either independently within this age range is a challenge, right? But we identified last week that typically, fortunately, many of these are bedfellows. So you have comorbidities. Right, that I have diabetes, but I also have osteoporosis. I have this and that and that and that. Right. One of the things we tried to address last week was the issue of having access to a range of professionals, but within one facility or one location. How is this handled? By all means, there'll be the need for referrals. You refer between and among professionals. How is this typically handled so that it benefits the people we're talking about, the elderly? Doc,
okay, so we will have to start from somewhere. As it stands now, most places don't have, if I'll say, multidisciplinary team that specifically cares for older people.
Okay.
But especially where I train, I am a geriatric fellow in training, so I'm also training to be a geriatrician. One of the approach is to have other specialists or other healthcare workers being in consultation with us to help us in assessing the older person.
Okay.
And so that is one of the ways in dealing with having to move from one person to the other. So by the time the person would even see the doctor for his medical care, the physiotherapist has done an assessment of the joints, of the movement, of how slow or fast the person walks and all that. And to assess his or her risk of falls. The clinical psychologist is also available to help us with some of the issues thereabout. Often, the people we don't get always is a social worker. We had the opportunity of working with a few social workers at a point because they came in as attachments and all that, and they were very helpful because they also could give us perspective to the circumstances that usually they would be living in, and getting that requires a lot of change in usual practice and thinking about the system in the way. For A fit 40-year-old person who might even have hypertension, diabetes, might be taking 4 or 5 drugs. It really might not change much about his or her management.
Okay.
But for someone who is 60 years, who is 40, who is taking 4 or 5 drugs, a lot of things change.
Seeing 3, 4
specialists.
Right.
A lot of things changes. He does not even have the ability to move from one place to the other like the old person, the younger person will have. He does not have even the funds to acquire the expensive medications that we would require him or her to have. And so we need people who can help, and if I'll say, help them even know their kind of social networks that can help them in sorting out their problem.
Right. We need, let me call that the ideal, the desired. How do we help them as we speak today? Kokumemle, Fili. Is it that you have, years back, I still do. I did a lot of work in domestic violence and management, but we developed what we call the GVSSN, right? Gender Violence Victim Support Network, such that if I Nortey write a referral to a court or to a this or that or that, all the related professionals respond to that referral with a bit more promptness and urgency, right? If you now needed a cardiologist to do something for an elderly patient, and we've said and emphasized that the model of geriatric medicine says that, look, we must treat these things with sensitivity, dispatch, urgency, and so on and so forth. Does it mean that when that person goes to the specialist you're talking about, albeit not in the same physical structure, will they get that same prompt attention, right? So they go to a cardiologist or a renal specialist, right? Or are they just going to jump into the pool and then they realize I'm still in Ghana?
I get you very well.
How does it work, or how should it work whilst you are finalizing this legal policy document?
Good. So one of the strategy is to have what we will call a pilot center that looks at the care of the older persons. And unfortunately for us, geriatric Tetekwashi, where I work, is the pilot center that we are looking at. So we are building capacity, that is internal capacity among the healthcare practitioners to be able to address the pertinent challenges with regards to the older person's care. And that also requires us to look at our linkages in terms of referral to a cardiologist and all that. And that's what we are also looking for. So for instance, if we are referring a patient for a cardiologist review, it is mandated that you make a call directly to the cardiologist so that the person knows where he or she is coming from, what the challenges are, because he, the cardiologist, might not have all the time to go through all the things that are required by that older adult. But once he is given a perspective from his primary carer, it becomes easier to be able to help such a patient. A lot of times we've had patients who, when you are referring from the sub-district or the district, they would just come back and say that, no, I'm not going because that place is too... that
is exactly the place they wanted to avoid. Right? Unless they have a big man stamp like George Aqua, Ernest Enimo Parry, or Dr. Kwesenu, right? That's why I was trying to see whether we have any system accommodations, right, that cushion them and make sure that the very self-same objectives we have exposed our listeners to are actually manifest, along the line. But I understand the challenge as well. Right, George, were you going to add something?
Yeah, I'm thinking at the moment, as this now, there are no clear-cut procedures as to how to receive the elderly in our normal clinics, Ghana Health Service, and the private facilities. So now that the awareness is heightening, we must as well as practitioners put it to the fore that people have to prioritize the aged and then treat them separately. So we don't have to put them into the normal queues. There should be a seating place for the aged, and even the environment within which they come to a typical hospital should have walkways and ramps for the elderly friendly
right.
Environments.
Okay.
Yes, so that we can be able to target
we're still
them.
Playing catch up with that one.
Yes.
All right. But would you say, and I know George typically, I don't know about the other two, though you all do galamsey. Would you quickly just say that has the private sector caught up? Is it better? Because, financial access is a big problem, especially for this age group. But typically they find that the public service is deficient, and therefore if they want home health care helps, they want nurses, they want physiotherapists, they want anybody to come home, or for them to go to them, they have to fall on the... Is the private sector doing better? Are they more tuned to these needs, or is the same story?
Some of them, the information the scenario is becoming more clear to people, and then they are beginning to see the need. A few places have happened to work that now these days they look at the elderly more than younger people. So it's no longer now first come first served.
But at a price.
But no, at the same price. But then they give priority to the elderly. Likewise, when it comes to reviews and things, they try to shorten things as much as possible. If they can do a phone call and tell you what to do instead of getting you to come over. A few centers.
So if you can, you should explore some of these things, bearing in mind the pillars and the tenets we talk about. Okay, this was just quickly. I'm just trying to wrap up. We're already over time. I read somewhere that taking calcium tabs without taking vitamin D3 and K makes it a useless venture. That the calcium will not be absorbed. Is that true? No, Sue. Is there anything, I think, related to the bone density matter?
Yeah, so vitamin D helps in the absorption of calcium.
Okay.
But I mean, again, like Dr. Kwesenu said, it's not as though taking calcium or vitamin D supplements in themselves would prevent you from having osteoporosis. There's an underlying hormonal change. So sometimes, in addition to the supplement, we actually give some hormonal replacement therapy because we know they've declined in terms of concentration in the blood.
Right. There must be something there before you supplement it. Agbena. Right? When you get up and you go and buy supplements, maybe there's an underlying problem that tells you that the thing that you are supplementing is not even happening. So that's what Dr. Enimo Pari is saying, that we need to identify what is happening before you even start giving pharmacy or anything your money by way of supplements. And they are supplements. They are not labeled or categorized as treatments. Okay, mindful of that. I hear noise in my knee when I walk or when I bend my knee. Good afternoon. This is a free far from Wager. He hears noise in his knee. He hasn't specified age.
Yeah, so it's one of the things that it could be a feature of arthritis. In this case, possibly osteoarthritis of the knee. It's typically called crepitus, where you hear some noise coming from it, like
bent on giving us painful names this Sunday.
Okay, so you should come to the hospital then.
All right, no, just finish that so that we wrap.
Yes, so I'm just saying that it's one of the symptoms of having pain and then some noise associated with movement. It's usual characteristic of arthritis. So the patient would have to come to the hospital. An X-ray will be done, and then the possible treatment modalities will be rolled out. All
right. A free fine wage. I hope we've answered your question. Crepitus is possible, not confirmed. All right. It could be arthritis. So I would say creep towards, since it's crepitus possibly, creep towards the health facility. Radio can only take you so far. Right. We've gone past our 3 o'clock mark. But thank you, gentlemen. I still need more. You see, the more practical I try to be, the slower we go, but the more beneficial the program is and the discussion for our listeners. Thank you so much, Dr. Frank Jifa Pesenu. He's with the Tetekwashi Hospital in Mampong, and he's the acting coordinator of the National Healthy Aging Program at the Ghana Health Service. Next to him, Reverend Dr. Ernest Enim Opari. He's with the Kolebu Polyclinic Family Medicine Department. And Dr. George Aqua is with the Department of Community Health at the Kolebu Teaching Hospital. If you want to contact any of them, those are the facilities you can find them. Unfortunately, I cannot give you or give out their phone numbers, but we'll continue on this elder care line possibly next week. We'll look at some of the other issues and see how we can improve the quality of life of our elder Ghanaians. Thank you once again for listening, my discerning listeners. Thanks to my producer, Abeku San Kofi, for the extra few minutes. And I think he has some smooth high life mix coming up. Stick and stay on Joy 99.7 FM. My name is Nortey by nature. I'm out.